Thank you very much, Professor Ladas. Good morning, ladies and gentlemen. It's very nice to be back in Athens, in my home country, and to be surrounded by many friends and actually even schoolmates of mine that I was very, very pleased to see here in this audience. I'm going to keep you busy for the next 20 minutes discussing the very common theme of refractory gastroesophageal reflux disease. So as we all know, we use proton pump inhibitors both in primary care as well as specialty care. And what can happen when we use PPIs? We can have three scenarios. One is that we get a complete response. That means the patients have no symptoms whatsoever while they're taking the drug. We may have the partial responders who tend to have what we call breakthrough symptoms, or we may have those who do not respond at all to medical therapy. They have absolutely no change in their symptoms. And as you can see here, these two categories of patients comprise what we call refractory reflux disease, and this is going to be the main theme of my talk. So what is refractory gastroesophageal reflux disease? It means usually the clinical significant impairment in the quality of life of the patient due to episodes of reflux while they are receiving proton pump inhibition therapy. Keep in mind, though, that the refractory symptoms may not be only related to acid, but they could be related to the refluxate volume, which continues to exist despite the use of the drugs. It could be related to esophageal distensibility from either gas or fluid, or it could be, obviously, a reflection of sensitivity to acid, and different individuals may have different levels of such sensitivity. How do we assess for refractory gastroesophageal reflux? We have two basic categories. We have a structural assessment in which we assess the structure of the esophagus by doing endoscopy, biopsies, barium esophagography, or we can do functional assessment in which we study how the functionality of the esophagus is by using high-resolution manometry, ambulatory pH monitoring, something that's called endoflip technology, which allows to measure the distensibility of the gastroesophageal junction. And sometimes we use gastric or esophageal scintigraphy to assess esophageal and gastric transit times. Endoscopy, of course, is a pivotal element in the evaluation for structural abnormalities of the esophagus, such as what you see here, eosinophilic esophagitis. You can see Barrett's esophagus. We can see severe esophagitis with esophageal stricture. Or more commonly, we see a patulous gastroesophageal junction that is not damaged in any way other than the fact that it is quite open. We can use esophageal biopsy to characterize the structure of the esophagus, and an important condition here in the refractory GERD patient is to rule out the possibility of underlying eosinophilic esophagitis, and obviously the condition called Barrett's esophagus with a characterization by the columnar cells, so-called intestinal metaplasia. We also use high-resolution manometry, which you see here, compared to the traditional manometry. You see you can study the peristaltic functionality of the esophagus, the relaxation of the gastroesophageal sphincter. So this is an important tool in the assessment of the functional capability of the esophagus. And we have the endoflip technology, which allows us to measure the distensibility of the gastroesophageal junction. And this is particularly important in patients who have possibly previously undergone fundoplication. You assess the functionality of that surgery. I would like to share with you some rules in the game of refractory GERD. First of all, please remember that not all GERD is the same. You have a condition called non-erosive reflux disease, or so-called NERD, which is a very common, accounts for about 70% of the cases. We have the erosive esophagitis types with the classification by Los Angeles B, C, and D classes. We have those who have or who do not have a hiatal hernia. We have those who have refractory reflux. We have those who express the consequences of repair, such as stricture formation or Barrett's metaplasia. And then we have another group of individuals who express pulmonary or even ear, nose, and throat manifestations such as laryngitis and cough. So as you face with a patient who has so-called reflux symptoms, remember that they could be reflux-related or they may not be reflux-related. Always keep that possibility in your mind. And if it is reflux-related, you have the categories of erosive reflux disease, of non-erosive reflux disease, and of Barrett's esophagus are separate categories sometimes that define the patient a bit better and allow us to manage them accordingly and differently. The second rule is, do we have a hiatal hernia? And this is an important rule because if there's a hiatal hernia of significant size, usually more than 3 centimeters in length, typically we have an association with a foreshortened esophagus, and sometimes the best solution for these patients is the performance of a laparoscopic Nissen fundoplication. And then it is important to consider all options individually. So every patient will somehow be addressed specifically depending on their individual characteristics. So we have options such as endoscopic therapy. And under endoscopic therapies, we have the so-called strata, which is radiofrequency energy application to the lower esophageal sphincter, or we have the transoral incisionless fundoplication, which is an endoscopic modality that we do basically a reconstruction, almost a partial fundoplication endoscopically. And then we have surgical approaches, which is the fundoplication in most patients, but increasingly so in the patients with morbid obesity. The answer probably would be to perform a gastric bypass surgery, which actually cures them of the reflux and at the same time addresses the issue of obesity. So assessment of the body mass index is very important in this decision. And then I will talk briefly about novel therapies that are exciting and appear in the horizon in Europe as well as in the United States and elsewhere. Let's start with a case. There's a 44-year-old man with a 6-month history of dyspepsia, regurgitation of sour fluid and belching. He does not have any weight loss. He has failed to respond to a 6-week trial of omeprazole. Past medical history is significant for hypertension, type 2 diabetes, mild obesity. He takes lisinopril, metformin, and insulin. On examination, he has mild epigastric tenderness, and he's guaiac negative. So this is the scenario of someone who has refractory reflux. Well, let's think about what would be the best next diagnostic step. Should we do an ambulatory pH monitoring? Should we do a barium esophagography? Should we do a CT scan of the chest? Or should we do an esophageal manometry? Well, the answer is to perform an ambulatory esophageal pH monitoring. This technology allows us to assess for the presence of gastroesophageal reflux, quantifies the reflux, and gives us an appreciation of the magnitude and its severity as well as its relationship to symptoms. Barium esophagography would not be useful. A CT scan would not be useful in the particular context. An esophageal manometry could be useful later on, but not at this point in time that we're trying to find out if this person has reflux disease. As I mentioned earlier, 24-hour pH monitoring has a very good performance rate with a sensitivity and specificity of more than 90%, allows us to correlate the symptoms to acid reflux, and we can do the study both off as well as on medical therapy. So as we face with a patient with refractory reflux disease, by doing esophageal pH monitoring, we can define if they have normal esophageal acid exposure or abnormal esophageal acid exposure. If they have abnormal esophageal acid exposure, then by definition they have acid reflux. If they have normal esophageal acid exposure off medical therapy, we know that there must be something else causing their reflux-like symptoms. And these are the general categories that we need to consider under the circumstances of a patient who does not have abnormal acid esophageal exposure. We need to consider achalasia another dysmotility syndrome, such as diffuse esophageal spasm, jackhammer esophagus, etc. We should consider eosinophilic esophagitis, which is very, very common in the West in particular. We should consider something that's called reflux-like dyspepsia, which is more of a gastric symptom or syndrome, but it's presenting with esophageal symptoms. And we also need to keep in mind the possibility of gastroparesis, which presents mostly with heartburn and acid regurgitation in about 15 to 20% of cases. And sometimes we may need to do a gastric emptying scan, which is a scintigraphic method to assess gastric emptying, to quantify the delay of the gastric emptying and allow us to make the diagnosis more correctly. Let's look at another case. A 34-year-old woman presents with heartburn, frequent need to clear her throat, fleeting retrosternal chest pain, and intermittent dysphagia. She also has frequent bloating, belching, and flatulence. Her symptoms of reflux improved about 50 to 60% with the use of dexlansoprazole, 60 milligrams every day before breakfast. She has a history of asthma and irritable bowel syndrome for more than 10 years. On clinical examination, she has mild bilateral wheezing, her abdominal examination is normal, and her stool is guaiac negative. Which would be the most appropriate next diagnostic step? To do an ambulatory esophageal pH monitoring on the drug, on the PPI, to do an esophageal manometry, to consider anti-reflux surgery, or to do an endoscopic therapy? The answer to that is ambulatory esophageal pH monitoring while the patient is taking the PPI to define if indeed the patient's symptoms are a reflection of persistent abnormal esophageal acid exposure. And this is the example here. What you see, you have two lines here. One is the top line that shows the intraesophageal pH. The thicker black line is the intragastric pH. You can see here that during the night in particular, you have a residual acidity in the stomach, and also during the day and night, you have some episodes of persistent esophageal acid exposure with frequent drops below the 4.0 mark of this top line here. And this allows you to define the presence of ongoing pathologic acid exposure. Now, this is a study that actually reminds us that PPIs may actually lose their efficacy over time. And the more we use PPIs in our clinical practice over time and with higher doses, the more we will see this phenomenon of escape, if you will, of the intraesophageal pH control. And this is a study that initially the pH was high. At the beginning of treatment, it went down. And then 2 years later, you will start seeing this escape with abnormal esophageal acid exposure after 2 years of ongoing PPI therapy. And this is a study that we just presented at the DDW in May, where we took patients, 172 patients, we optimized the PPI, we looked at them, once daily PPI users and twice daily PPI users, and you can see here that a significant proportion of patients either on once daily PPI therapy or twice daily PPI therapy who had actually well-controlled symptoms, they continue to have esophageal acid exposure. So remember that this is an important tool in the management of patients with refractory reflux disease. How do we manage those patients? We make sure that they're compliant with their drugs, their lifestyle is correct, that they're adhering to the medical regimen. Sometimes we may have to switch from one agent to another, or to use another PPI, or to use the same PPI twice daily. We want to make sure that it's given before meals. And sometimes we use other pharmacologic approaches, although these pharmacologic approaches are not generally very effective. So when we're faced with this pharmacologic failure, we have basically two choices. One is the choice to proceed with an endoscopic therapy. The other one is to proceed with a fundoplication. Let's look at another case. This is a 55-year-old man with worsening heartburn. He has had heartburn and regurgitation for more than 5 years that they were well controlled with once daily omeprazole. However, over the past year, he has frequent breakthrough symptoms which responded to once daily esomeprazole. He tried increasing the esomeprazole to twice a day, but this resulted in diarrhea. He has no weight loss, no early satiety, no nausea, no vomiting, no dysphagia. He's otherwise healthy, normal physical examination, BMI is 29. However, on endoscopy, what you can appreciate here is that he has erosive esophagitis and a significant hiatal hernia. There was no Barrett's esophagus endoscopically or by biopsy. Which of the following is most likely to improve this patient's symptoms? To add metoclopramide, which is a prokinetic, to add a sucralfate, which is a surface protectant, if you will, to increase the esomeprazole to twice daily and use an anti-diarrheal at the same time, or to consider performing a laparoscopic anti-reflux procedure. The answer is perform a laparoscopic fundoplication. Fundoplication is a very important tool in our management of refractory reflux disease, but it should be used for selected, highly carefully characterized patients and by expert surgeons. In general, community setting results are, or results that are on poorly evaluated patients may be inferior to the ones that you see in clinical trials. And you also need to be aware of that persistent or recurrent symptoms may occur in up to 30% of patients. And about less than 10% of these failures undergo a revision, and usually revisional surgery is much harder to do and much less successful than the original one. So we have a situation, as you look at the big picture of reflux, that you have a very small percentage of people who are undergoing anti-reflux surgery, about 5% of patients. We have a large group of patients, about 60 to 70% of people who are doing okay with proton pump inhibitors and adjustment of the dose. And then we have a group of people who are not fully satisfied from PPI therapy, who are not willing to undergo surgery because of sometimes its bad reputation or they're afraid of surgery. And this is a situation that we face nowadays, at least in the United States, in about 20 to 30% of our patients. And this gap is now being the key element that we need to address with either endoscopic therapies or other new novel therapies that we are developing. Now, how about endoscopic therapies? The reasons to consider endoscopic therapies for reflux is predominantly the refractory GERD, those who have PPI intolerance, about 2% of the total number of patients. There's another group of individuals who desire to stop drug therapy because they're concerned about long-term side effects. There is a group of people, of course, that are afraid to undergo fundoplication. And there's a group of people actually who actually have symptoms after a previous fundoplication. So these are the potential areas that we can somehow cover with endoscopic therapies. Stretta is radiofrequency application to the sphincter, which is delivered endoscopically at this point, at the gastroesophageal junction, and it enhances the sphincter pressure, it reduces the transient sphincter relaxation frequency, and improves symptoms. And this is a recently published meta-analysis of gastroesophageal reflux quality of life scores, and you can appreciate here the before and after results, which are highly significant, and the Hartman scores quite significantly improve. We have data up to 10 years after Stretta, and you can see that if you look at the quality of life scores off medical therapy, on medical therapy, and then after the procedure, 1, 4, and 10 years later, you can see that the results are quite long-lasting. The transoral incisionless fundoplication is another endoscopic modality to treat reflux, and what we do endoscopically with the use of a special equipment, we actually reconfigure the gastroesophageal junction, and that actually has also some impressive results as shown here. The data is not as long-term as we would like to be, but it's been accumulated. And you can appreciate here that if you look at the PPI used after incisionless fundoplication, you have a significant reduction in the usage of PPIs. Something that's important to remember is who are not the good candidates for either endoscopic or surgical therapy are those who have what we call functional heartburn. This is a group of people who have absolutely no response to PPIs. They have all kinds of things. The French call it le malade du petit papier. And those who have negative pH studies and no symptom correlation with acid events. It's best to leave these people alone, not to do any endoscopic or surgical therapy because they are going to be the failures of our intervention. And then I would like to talk briefly about some novel therapies that have been developed. The LINX system is the application of a ring of magnets that keeps the gastroesophageal junction tight. And this has been introduced in the United States and Europe. The data is excellent, as I will show you in a minute. The procedure is done under laparoscopic guidance, but it takes a very short period of time, and it does not require any surgical mobilization of the tissues, and it can be done by a relatively inexperienced surgeon, if you will. The other one is the lower esophageal sphincter neurostimulation, which is also at this point in time done laparoscopically, and we implant some electrodes at the gastroesophageal junction that then are connected to a stimulator, and the muscle of the lower esophageal sphincter is stimulated intermittently and allows for hypertonicity, if you will, of the muscle and excellent performance in terms of reflux scores. Here's the data from a recent review on the LINX implantation. This is the magnet at the level of the gastroesophageal junction, and you can see here 100% of people were using PPIs initially, and only about 20% of them are using it at 4 years. This is the neurostimulation by the endostim approach, and you can see here the electrodes are implanted at the lower esophageal sphincter. They're connected to a little pacemaker-like device at the abdomen. And what you see here in an open trial, you can see the GERD-related quality of life scores as well as the pH control before 3 months, 6 months, and 12 months later. Very, very impressive preliminary data. So in summary, when we have a patient with refractory gastroesophageal reflux, we look at the presence or not of significant hiatal hernia. 2 to 3 centimeters is a real hiatal hernia there. If there's no hiatal hernia, strata is an option, and if that fails and one needs to use PPIs on top, either a repeat strata or a LINX or a fundoplication or a TIF could be used. If there is more than 2 or 3 centimeter hiatal hernia, a LINX or a fundoplication procedure could be done, and if that fails, then it can be treated again with PPIs or with endoscopic therapy, such as strata or TIF, or go to a redo fundoplication. So in conclusion, refractory reflux symptoms may or may not reflect gastroesophageal reflux. Structural as well as functional evaluation are essential. There's an emerging role of endoscopic and newer surgical therapies, and obviously a combined approach by multiple disciplines such as gastroenterology, gastrointestinal surgery, and interaction with our other colleagues maximizes successful outcomes. Thank you very much.